Okay, so before we go see my patient, I'm gonna place a labor epidural on. I'm gonna do my machine check. So I'm gonna make sure that it's plugged into AC power into the wall. I'm gonna check my auxiliary O2 tank, make sure it has enough pressure. And then I'm gonna check my pipeline pressure to make sure all those are full at 50 PSI. And then I'm gonna look at my vaporizers, make sure the screws are on tight, they're nice and full, the interlock system works. While my machine's off, I'm gonna do my low pressure test, turn my machine on. And then I'm gonna make sure that I have my ambu bag, my suction is working, and test that. And I have all my monitoring equipment like my EKG, pulse ox, blood pressure cuff. And then I'm gonna check out my CO2 absorbent, make sure it's not desiccated. And then I'm gonna do my O2 analyzer, and I'll do my high pressure test. I'm gonna include my APL valve, or sorry, close my APL valve, include the wide piece, and then press my O2 flush. I should be able to maintain 30 centimeters of water pressure for at least 10 seconds. I'm gonna take a look at my inspiratory expiratory flutter valves. Check my vent settings, I think I already said that. And then I'm gonna look at my thorpe tubes and make sure I can't create a hypoxic mixture there. And then my equipment that I have for my specific patient, I have a 7.0 ET tube, a half size below and above. I have my Apple's drugs, I have a face mask, I have a MAC 3 if I need it. I've got tape in case I need it. So my machine check should be done and I should be ready to go. I'm gonna go talk to my patient, who is a 35-year-old female. She's here for vaginal delivery of a baby. She has a history of smoking, and she's a G1P0, ASA2, 175 centimeters and 65 kilos. I reviewed her labs in her chart, and so I'm gonna go talk to her about placing her epidural. So I'm identifying the patient, and then I'm gonna explain the plan, the risk, benefit, and alternatives. So I'm gonna be placing a needle in your back, and it's gonna go right into the space before the spine and numb all the nerves so that you have great pain control during delivery. So the rest of this procedure, you can have bleeding, a hematoma or abscess, you can have infection anytime or poke in the skin. You can have permanent nerve injury, a post-dural puncture headache, nausea, difficulty breathing, hypotension, bradycardia, tachycardia, failed or faded block, or you can have a total spinal or pain on injection. So the benefits of this though is the great pain control that we talked about, not having to use a general anesthetic, and then you also have decreased risk of clots forming due to immobility post-delivery. And then you also, if you don't choose to get an epidural, you can talk to your OB team about alternatives such as like ibuprofen or nitrous that you can use instead. So now that I've gained consent, I'm going to gather my supplies, make sure I have my appropriate PPE. I'm going to put on a mask and make sure my kit has my medications that I needed, my Lido, my test dose medications, and then my starting bolus. And then I'm going to make sure that I have my sterile gloves that are my size and my epidural kit. I think I talked about already. Okay, so I'm going to make sure that the patient is in a good sitting position. She's going to be bent over with, pillows like this and pushing her lower back out like a mad cat. And then I'm going to make sure her monitors are all on. So she's going to have a BP cuff on, pulse ox and EKG on. And then I'm going to identify my landmarks. I'm just going to take a look at her spine, look at the tooth ears line or the intercostal line here, and kind of find the spinous processes and find a good spot that I think I'm going to try to poke at. Okay, so next I can open my kit very sterilely, and I'm going to take my sterile prep and prep the patient. Then I'm going to put on my sterile gloves and using my sterile drape. I'm going to drape the patient. It already is, I'm going to leave that over here. Okay, then I'm going to take these all out and kind of arrange my kit and get my Lido needle set up. It's gonna be 1% lidocaine and a 3 ml syringe with a 25 gauge. I'm gonna do a little skin wheel with that. Put that in my little sharps container. And then I'm going to take my NS and get my loss of resistance syringe all primed up for me. I like air with a little bit of NS in there. And then I'm gonna take my tuning needle, if I can get this thing off. There we go. Okay. All right, and then bevel up. I'm gonna insert a little bit of stuff in that. Until I feel resistance. Once I feel resistance, I'm gonna pull out this stylet, and then I'm gonna use my loss of resistance syringe. To find the epidural space. I'm gonna be using a bromage technique to make sure that I can stabilize my hand here on the patient's back. And then I'm going to be kind of pulsating on the plunger until I find a loss of resistance, which I find. And now I'm going to remove my loss of resistance needle, or sorry, not needle, but syringe. And then I'm knowing the length on my 2E catheter, or 2E needle, see how far in it is. And now I can thread my epidural catheter. Okay, now that that is threaded, I'm going to pull back on the 2E, and I'm going to keep threading it to make sure that catheter stays in place. And I'm going to note here the distance my catheter is at needs to be at least 5 centimeters into the epidural space. And so I can see here that I have 15, 14, I'm at 13 at the skin. So now I can tape this, I'm gonna tape it up over the shoulder for my patient, and I can try with my test dose. So my test dose is gonna be 3 ml lidocaine, that's 1.5% with epi, which is 1 to 200,000. So that would be 15 mics. So I'm going to take my medication, give this test dose, and while I give this, I'm going to explain to the patient what I'm doing and what symptoms I'm observing for. So if we have an intrathecal or spinal placement, then the patient may feel instant warm in the feet or legs, and then we can also have a rapidly developing higher block than anticipated. And then you can also have an intravascular placement, which I would see from the epi an increase in the heart rate above 20 points from their baseline. Or you could also see last symptoms from the lidocaine, so like tinnitus, metallic taste in the mouth, and things, and then seizures obviously too. So I'm not observing any of those over a few minutes. So I'm feeling good about my placement for this epidural, so I'm going to give the initial starter dose, which is 0.25% bupivacaine, 8 mLs, and then 100 mics of fentanyl. This is a total of 10 mLs. And then I'm gonna push it over 5 to 10 minutes in 2 ml increments. Okay, so now I'm knowing the patient's vital signs, and I'm gonna document and chart their vitals and comfort level Q5 minutes for times 3. Okay, so now I'm getting ready for my spinal. Okay, so like any patient, we're reviewing the chart and the labs, identifying the patient, explaining the risk benefits and the alternatives for this, which are similar to the epidural. And same as the epidural, I'm inserting a needle, this time intrathecally, into the spinal canal to help manage the pain. And this can, you don't have to use general anesthetic sometimes. You can just get away with using a spinal and sedation with this. Has similar risks. You can get nerve damage, hematoma, abscess, spinal headaches, total spinal backache, hypotension. You can have a failed or faded block, death, nausea, vomiting, bradycardia, tachycardia, pain on placement, infection, and then difficulty breathing. But the benefits, like I explained earlier, are the decreased risk of clotting post-op, and then also the great pain control and not having to use a general anesthetic. So first I'm going to make sure my patient's in a good position. Again, bending over and really exposing that lumbar spine. And they have their monitoring on. And then I'm going to identify my landmarks. Same spine, tooth ears line. I'm going between L3 and L4, just like the epidural. Okay, so I already have my mask on, and I open my kit sterilely. And then I'm going to prep the patient, get their back really nice and clean, and kind of looking at their landmarks and spinous processes while I'm doing that, feeling the bony prominences. Okay, so now I'm done prepping. I can put on my sterile gloves and drape the patient, already draped. And I'm going to set up my spinal kit. I can set up my Lido, my syringe here. I'm going to use another 25 gauge and then 3 mLs of 1% lidocaine for my skin wheel here. And then I can also use that as my introducer needle to kind of find where I want to go on the patient. Stick that on my sharps pad. Okay, and then I'm going to start with my introducer needle. Using the Bromage technique. And this time the bevel is going to be to the side. Okay, now I'm going to use the spinal needle. And when I do the spinal needle, I'm going to feel through all the layers in the back. And I should feel a pop when I get through the dura. Okay, once I feel that pop, I can remove the spinal needle. And I should see remove the stylet, and I should see a free flow of CSF. Okay, and now I can inject my medication. So I'm going to be doing 0.5 mils per second. And as I do this, I'm going to aspirate to make sure I have CSF coming back. So again, using the Bromage technique with my needle in there, I'm going to aspirate, inject half, aspirate again, and then inject the remaining. And then I'm going to pull everything out, the spinal needle together. Stick that in my sharps pad. And then depending on the procedure for the patient, I'm going to place that patient in the proper position based off the voracity of the medication as well. And then I'm going to observe the patient's comfort level, their vitals, and do my charting. And that's all.